Welcome to the funnel effect.
Today we're doing a deep dive into, well, a really significant area in cardiology right now. We're looking at how we evaluate and manage chronic total occlusions, CTOs, especially when thinking about revascularization.
Yeah, and this is grounded in some serious expertise. We're basing this on a major clinical consensus statement. The full title is Evaluation and Management of Patients with Coronary Chronic Total Occlusions Considered for Revascularization, a clinical consensus statement of the European Association of Percutaneous Cardiovascular Interventions, EAPCI, of the ESC, the European Association of Cardiovascular Imaging, EACVI, of the ESC, and the ESC Working Group on Cardiovascular Surgery. The primary corresponding author, Alfredo R. Galassi.
That's a mouthful, but it shows the weight behind it. It brings together interventionalists, imagers, surgeons, everyone.
Exactly. So our mission here, for you listening, is really to break down what this means, especially for referring physicians. We want to make sense of this comprehensive care track and focus on two things: the latest in pre-procedural evaluation, especially imaging, and the real clinical effectiveness of these CTO procedures.
And it's timely, because CTO management, it's seen impressive progress, as the paper puts it. Things have changed fast. So if you're a GP or a non-interventional cardiologist, understanding this new standard of care is, well, it's crucial. What was once almost impossible is now quite achievable.
It really has shifted, hasn't it? The whole landscape feels different.
Completely. We have better tools, better imaging, better techniques. It demands a new way of thinking about these patients right from the start.
Okay, let's get down to basics first. What is a chronic total occlusion? What's the official definition from the CTO Academic Research Consortium, the CTO IRC?
Right. The definition is quite precise. It's about an epicardial coronary artery being completely blocked, no forward blood flow, what we call TMI grade 0 flow. But the key part is the chronic aspect.
The time factor.
Exactly. It needs a probable or definite duration of at least 3 months. That's the minimum threshold.
And what happens inside the artery during those 3 months? Why does that duration make it chronic and so tough to deal with?
Well, over that time, the blockage changes fundamentally. Any fresh, soft clot or thrombus gets organized. It turns into dense, fibrous connective tissue. Think scar tissue, basically.
Okay.
And often it gets calcified, too, forming this hard cap at the entrance. So angiographically, you look for signs of this maturity: no obvious thrombus, no staining, and importantly, you see well-developed collateral vessels.
Ah, the bypass routes the body makes.
Precisely. Those collaterals take time to grow properly, so their presence supports the idea that the blockage has been there a while.
Given how tough that fibrous, maybe calcified blockage sounds, how often do cardiologists actually encounter these CTOs when they do an angiogram?
It's surprisingly common. The data suggests CTOs show up in about 15 to 20% of patients who are undergoing invasive coronary angiography for whatever reason.
Wow, 15 to 20%. That's like 1 in 5 or 6 patients in the cath lab.
Pretty much. It's a significant chunk of the workload.
So with that prevalence and the difficulty, I imagine the traditional approach was limited, mostly just medications.
Historically, yes. Very limited. And success rates for trying to open them with PCI, percutaneous coronary intervention, were much lower, sometimes below 60%. If you couldn't even get a wire through that hard cap, the procedure was basically over before it started.
Right.
The huge progress we're talking about now really comes from two main areas working together. First, much better pre-procedure assessment, especially using advanced imaging, which we'll definitely get into.
Okay.
And second, a whole new toolkit. We have dedicated CTO guide wires designed to penetrate that tough tissue, microcatheters for support, techniques like rotational atherectomy to drill through calcium, just a whole arsenal we didn't have before.
That's led to this big jump in success rates, right? That's the aha moment.
Absolutely transformative. Now, when CTO PCI is done by experienced operators in high-volume specialized centers, the success rates are consistently hitting 80 to 90%, sometimes even higher.
80 to 90%.
Yeah. It's moved from being a bit of a long shot to a standard, predictable procedure in the right setting.
So if I'm the doctor seeing a patient with a confirmed CTO, based on this consensus, I'm really looking at 3 main management paths to discuss.
That's right. Option 1 is optimal medical therapy, or OMT. That means maximizing medications for symptoms and risk factors. Option 2 is the CTO PCI we've been discussing. And option 3 is coronary artery bypass grafting, CABG, surgery.
Surgery still plays a role then.
Oh, definitely.
How-
Especially if the CTO is part of more complex disease like multiple blockages, or if the anatomy is just not suitable for PCI. The whole point of the consensus algorithm is to help clinicians weigh these options and choose the best path for that individual patient.
Okay, let's think about the patient themselves. Where do these CTOs typically get discovered? Is it always obvious?
Not always. They can turn up in different situations. Sometimes it's during an investigation for an acute coronary syndrome, an ACS. Other times it's when evaluating someone with stable symptoms, like ongoing chest pain or maybe shortness of breath they get with activity.
Stable angina or dyspnea?
Exactly.
Yeah.
But interestingly, they're also found quite often, incidentally, like someone's getting an angiogram before major valve surgery or a vascular surgery just for risk assessment, and boom, there's a CTO they didn't even know about.
That incidental finding must make the decision-making harder. If someone has clear symptoms, the path seems clearer. But what about these asymptomatic folks?
That's the trickier group. If a patient has symptoms, especially exertional ones, it gives a pretty clear reason to consider fixing the CTO for symptom relief. But for the asymptomatic patient, particularly if their heart function, their left ventricular function, looks okay in that area, well, you tend to be more conservative initially. You'd need more detailed imaging, really proving there's significant ischemia or viability issues before considering an intervention. For them, the potential benefit shifts from feeling better day to day towards maybe improving long-term outlook, their prognosis, and that's where things get quite controversial, as we'll see.
Looking at the typical patient who does have a CTO, what does that profile usually look like? Are there common characteristics or other health issues?
Yeah, there's a general picture. CTO patients often tend to be a bit older than your average patient getting PCI. They're more likely to have diabetes. And they often present with a lower left ventricular ejection fraction, the LVEF, meaning their heart pump function is already somewhat impaired compared to patients with non-total blockages.
So it sounds like we're often dealing with patients who already have a significant burden of cardiovascular disease.
That's very common. And this complexity really underscores why the clinical context is everything. The consensus paper stresses you have to look at the whole patient. How old are they? Are they frail? Do they have other major health problems like severe valve disease or maybe really bad lung disease that limits them anyway? Or even cognitive issues?
Right, because fixing the artery might not change their overall quality of life if other things are the main problem.
Precisely. These factors heavily influence whether PCI is the right choice, or if maybe OMT alone, or even CABG, makes more sense for that specific individual. The goal isn't just opening the pipe, it's achieving a meaningful improvement in their life.
Let's drill down on the symptoms. The main drivers for trying to open a CTO are symptom relief, angina, dyspnea, but you mentioned patients might not always report these accurately.
This is a huge point, and maybe one of the trickiest parts, because the CTO develops slowly over months or years. Patients often unconsciously change their behavior, they just adapt.
Oh.
They might start taking the elevator instead of the stairs without thinking about it, or they walk slower. Or they just stop doing activities that used to bring on symptoms. So when you ask them, are you having chest pain? Are you short of breath? They might genuinely say, no, not really, because they've shrunk their world to live within their limits. They've normalized their limitations.
We might just put it down to getting older or being out of shape, maybe.
Exactly. And it's not always classic chest pain either. Shortness of breath, dyspnea, is actually just as common, maybe even more common than angina in CTO patients. And data shows that successfully opening the CTO often really improves that dyspnea.
So because relying on just asking them isn't enough, we need more objective tools. What validated questionnaires or scales does the consensus recommend using?
To get past that subjective adaptation, yes, we need standardized tools. The consensus highlights a few key ones. There's the Modified Seattle Angina Questionnaire, the SAQ that looks at physical limits, how stable the angina is, quality of life related to it. Then there's the Eurocol 5-dimension score, the EQ5D, which is a broader measure of general health status, and specifically for breathing, the Rose Dyspnea Scale, or RDS.
Using these gives you a real baseline number, right? Something you can measure against later.
Absolutely. It makes the assessment much more rigorous and allows you to objectively track whether the intervention actually made a difference to the patient's reported experience.
You also mentioned a couple of hidden factors that can muddy the waters with symptoms, silent ischemia.
Right. So those collateral vessels we talked about, they're often good enough to supply blood at rest, preventing a heart attack. But during exercise, when demand goes up, they just can't keep up. This causes ischemia, lack of oxygen, but the patient might not feel it as a typical pain. It's silent.
Still potentially damaging the heart muscle, though.
Potentially, yes, or at least limiting function. The other hidden factor, which is quite interesting, is depression. Studies have shown a higher rate of depression in CTO patients compared to other cardiac groups.
And depression can affect how people perceive or report symptoms.
It definitely can. It might blunt their perception of pain or reduce their motivation, making them less likely to report exertional symptoms accurately. It adds another layer of complexity to getting a true clinical picture.
Okay, so if symptoms can be misleading, imaging becomes absolutely critical. What's the main goal of using imaging when you're considering fixing a CTO?
The goal is really clear. You only want to revascularize a CTO territory if the heart muscle supplied by that blocked artery is, 1, still alive, viable, and 2, if it's actually becoming significantly short of blood supply under stress ischemic.
Viable and ischemic.
Those are the two pillars. Imaging is how we define the anatomy in detail, quantify how much ischemia there is, assess that viability, and ultimately that guides the decision whether to intervene and helps predict if the heart muscle is likely to recover function afterwards.
For the initial look at the heart's overall structure and pump function, what's the go-to test?
Standard echocardiography, or echo, is usually the first step. It's widely available, it's non-invasive, relatively inexpensive. It gives you that crucial baseline assessment of the left ventricular ejection fraction, the LVEF.
And that baseline LVEF matters for risk assessment too, right?
Yes, absolutely. We know that procedural risks are higher in patients starting with a lower LVEF. Plus, echo is great for screening for other problems that might be relevant, like significant valve disease or maybe an aneurysm.
All right, moving beyond basic structure to viability, is that muscle still alive under the blockage? What's considered the best test, the sort of gold standard now?
For viability, and actually for assessing ischemia too, stress cardiac magnetic resonance imaging (CMRI) is really considered state-of-the-art.
What makes CMRI so good for this?
Its main advantage is the use of gadolinium contrast, specifically looking at late gadolinium enhancement, or LGE. This technique provides incredibly detailed high-resolution pictures showing the exact extent and location of any scar tissue or fibrosis within the heart muscle.
And that scarring pattern, the LGE, tells you about the chances of recovery.
It does, and quite quantitatively. This is a really key point. If the LGE shows that less than 25% of the thickness of the heart wall in that area is scarred less than 25% transmurality, then it's highly likely that the muscle function will recover if you restore blood flow with PCI.
Okay, under 25% scar, good chance. What about the other end?
If the scarring is extensive, meaning more than 75% of the wall thickness is scar tissue, then recovery is very unlikely. In that situation, opening the artery probably won't improve the pump function in that segment. It's essentially futile for functional recovery.
That seems pretty clear-cut. Where's the uncertainty then?
The uncertainty lies in that big middle ground between 25% and 75% scar thickness. In that intermediate zone, the ability of LGE to accurately predict functional recovery is, well, it's much more limited.
A gray zone.
Exactly. And that gray zone helps explain why sometimes, even after a technically perfect CTO PCI on a segment that looked viable, we don't always see the dramatic improvement in LV function we might have hoped for. Biology isn't always black and white.
Makes sense. What if CMRI isn't an option? Maybe the patient has a pacemaker or defibrillator that's not MRI compatible, or they're claustrophobic. What are the alternatives for checking viability?
Stress echocardiography is another option, and it's used a lot. However, the consensus document points out that one common technique, low-dose dobutamine stress echo, which looks for contractile reserve, hasn't been found to be super sensitive for predicting recovery of really dysfunctional muscle.
So maybe not the best choice for severely impaired hearts.
It might be less reliable in that specific group. So often nuclear cardiology tests come into play. And among those, PET positron emission tomography is generally preferred over SPECT single-photon emission computed tomography, specifically for viability assessment.
Why PET over SPECT?
It boils down to better image quality and physics, really. PE offers higher spatial resolution, meaning it can distinguish viable tissue from scar more clearly. It also usually involves a lower radiation dose to the patient and can often be done faster, which is a plus for sicker patients.
Got it. Before we move on to planning the procedure itself, you mentioned earlier that CTOs aren't just a plumbing issue, they carry an electrical risk too. Can you expand on the link between CTOs and dangerous heart rhythms, ventricular arrhythmias?
Yes, this is a really important prognostic consideration. That area of chronic ischemia and the resulting scar tissue, even if it's not fully transmural, can create an unstable electrical environment in the heart muscle. It becomes a potential source or substrate for ventricular arrhythmias like VT or VF.
And this isn't just theoretical.
No, the data supports it. Studies show that having a CTO is an independent risk factor for worse outcomes, including higher midterm mortality in patients who present with ventricular arrhythmias. Also, in patients who already have an ICD, an implantable cardioverter defibrillator, because of known ischemic cardiomyopathy, having a CTO is an independent predictor that they will receive appropriate shocks from their device later on.
So the CTO itself is contributing to that electrical instability. It really highlights that managing a CTO isn't just about relieving angina. It might have deeper implications.
It absolutely does. It adds another layer to the risk-benefit calculation when deciding on management.
All right, we've assessed the patient, confirmed the CTO, checked viability and ischemia with imaging. Now we're thinking about actually doing the PCI. Angiography gives us the basic picture, but you mentioned CT scans, CTCA provide crucial extra details for planning.
Exactly. Angiography confirms the CTO is there, but CTCA gives the operator the detailed roadmap before they start. It provides vital information that's often hard or impossible to get just from the 2D angiogram.
Like what specifically?
Things like the precise location, and crucially, the pattern of calcification. Is it spotty? Is it circumferential? This dictates which tools you might need. It shows the shape of the ends of the blockage, the proximal and distal caps, are they blunt, making it hard to find the entry point, or tapered. It measures the exact length of the occlusion much more accurately than angiography, and it shows how twisty or tortuous the vessel is.
So it's like getting a 3D architectural plan.
Pretty much. This 3D understanding is fundamental for planning the strategy should we try going forward through the blockage, the antegrade approach, or do we need to plan for a retrograde approach, going backwards through those collateral channels. CTCA helps make that call up front.
And this detailed planning helps predict how difficult the procedure might be. You mentioned scoring systems.
Yes, operators use scoring systems based on these features to estimate the procedural complexity. This helps plan timing, allocate resources, and manage expectations.
The JCTO score, based on angiography, has been around a while, but the consensus paper prefers a CT-based score.
That's right. The consensus highlights that CTCA-derived scores, particularly the CT Rector score that stands for Computed Tomography Registry of Chronic Total Occlusion Revascularisation, have actually been shown to be more accurate than the older angiography-based JCTO score in predicting procedural difficulty.
More accurate in what way? Why is CT Rector better?
It seems better at predicting what really matters for procedural efficiency, how quickly and successfully the operator can cross the blockage with a guide wire. The JCTO score can sometimes underestimate the difficulty, especially if the proximal cap is hard to see clearly on angio or if there's heavy calcium hidden from view. CT Rector, using the CT data, gives a clearer picture of those challenging features.
So better foresight for the operator.
Exactly. It helps anticipate needing specific techniques or tools right from the start.
Okay, putting all this together, the symptoms, the complex imaging, the procedural planning, it sounds like the decision isn't always straightforward. This is where the heart team comes in. Tell us about that.
The heart team concept is really central to complex cardiovascular care now, and definitely applies to CTOs. It's a mandatory meeting, a multidisciplinary group discussion.
Who's typically involved?
You'll have the interventional cardiologists, cardiac surgeons, general cardiologists, specialists in cardiovascular imaging, and often cardiac anesthesiologists, especially if the patient is high risk.
And when is convening the heart team considered essential for a CTO patient?
It's crucial whenever the best path forward isn't immediately obvious. This definitely includes patients with lots of other health problems, older, frailer patients, and critically, patients with very complex coronary anatomy. Think left main disease or severe disease in all three major arteries, where one of them is a CTO.
So situations where PCI and surgery might both be options.
Precisely. The heart team weighs the pros and cons, the faster recovery and lower initial risk of PCI, versus the potential for better long-term outcomes, especially regarding repeat procedures that CABG might offer for certain complex anatomies. It ensures a balanced, patient-centered recommendation.
That makes sense for safety and optimal care. Speaking of safety, the consensus advises against doing CTO-PCI ad hoc, meaning right after the diagnostic angiogram finds the CTO. Why that specific caution?
It really comes down to proper preparation and safety. CTO procedures are inherently more complex and longer than standard PCI. They often take several hours, require specific equipment that might not be immediately available, and need a well-thought-out strategy, often based on that CT scan we just discussed.
So rushing into it isn't wise.
No. Doing it ad hoc doesn't allow time for the team to properly review all the imaging, get the right gear ready, and importantly, have a detailed discussion with the patient and family about the specific risks and benefits. Informed consent is key.
And regarding that consent, what specific risks need to be highlighted for CTO-PCI compared to a standard PCI?
Transparency is crucial. Patients absolutely must understand that CTO-PCI, while highly successful in expert hands, does take longer and carries a slightly higher risk of complications than opening a non-total blockage. The overall major complication rate is low, around 1 to 3% in experienced centers, but it's not zero.
What are the main risks?
Things like coronary perforation, making a hole in the artery, which might require draining fluid from around the heart, or rarely emergency surgery. Bleeding complications can also be higher due to the longer procedure time and anticoagulation needed. The consensus actually recommends using a specific consent form for CTO-PCI that details these differences clearly.
Okay, and finally on this, managing expectations. If the procedure goes well, what should patients realistically expect? What should we be careful not to promise?
This is maybe the most critical part of the conversation. We can tell patients with good confidence that successful CTO-PCI is very likely to improve their symptoms, reduce their angina, lessen their shortness of breath, and improve their quality of life. That's the main goal and the most proven benefit.
But what about the bigger picture outcomes?
That's where we need to be cautious. Patients must be told that based on the current randomized trial evidence, we cannot definitively say the procedure will make them live longer or reduce their overall risk of major adverse cardiovascular events, MC, like heart attack or stroke in the long run. The evidence just isn't strong enough for that claim yet.
So the promise is primarily about feeling better and doing more, not necessarily living longer based on current top-level evidence.
Exactly. Quality of life improvement is the solid ground. Prognostic benefit is still being investigated.
Okay, that distinction between symptom benefit and prognostic benefit is key. Let's start with the success story. Symptoms and quality of life. The consensus seems clear on this.
Absolutely. This is the least controversial area. The primary well-established reason to perform CTO-PCI is to relieve symptoms like angina and dyspnea and improve the patient's quality of life, especially if those symptoms persist despite good medical therapy, OMT.
And we have solid randomized trial data backing this up.
We do. 3 of the 4 major randomized controlled trials, EuroC2, COMET-CTO, and IMPACTOR-CTO, all showed significant benefits. For example, EuroCTO found much better scores on the Seattle Angina Questionnaire at 12 months in the PCI group compared to the OMT group, specifically in how often they had angina and how much it limited them physically.
Okay.
IMPACTOR-CPO even showed improvements in objective measures, like how far patients could walk in 6 minutes, showing better exercise capacity alongside the quality of life score improvements.
So consistent evidence across several trials that patients feel better and can do more.
Pretty much. There was one major trial, Decision CTO, mostly from Asia, which was actually neutral on the symptom outcome.
An outlier then.
Kind of. But given the strong positive results from the other 3 RCTs, plus a huge amount of supportive data from observational registries, the overall consensus firmly stands. Symptom relief is the primary proven indication.
All right, now let's wade into the controversy. Reducing MS major adverse cardiovascular events. This is where things get murky, with different types of studies seemingly saying different things.
This is precisely where the debate lies. We have a clear tension between findings from large observational registries and the results from the randomized controlled trials.
What are the registries suggesting?
The large registries, which follow thousands of patients over many years in real-world practice, have consistently suggested that successfully opening a CTO does lead to better long-term clinical outcomes, including lower rates of MEE and even death.
Can you give a specific example? That sounds quite significant.
The Korean registry is a powerful example. It followed over 1,500 patients using statistical matching to compare groups for 10 years. They found a really striking difference in mortality. 13.6% in the group that had successful CTO-PCI versus 20.8% in the group managed with OMT alone.
Wow, a greater than 7% absolute difference in death at 10 years. That's huge.
It is. And other registries, like a large Canadian one, have reported similar findings, lower long-term MA in mortality linked to successful CTO recanalization. These registry findings generated a strong hypothesis that opening CTOs improves prognosis.
But then came the RCTs, the gold standard for evidence. How did they stack up against these registry findings?
That's the problem. The major RCTs designed to test this hypothesis, Decision CTO and Explore, failed to confirm a significant reduction in MACE or mortality with CTO-PCI compared to OMT.
They were neutral?
Essentially, yes. Even EuroCTO, which was positive for symptoms, showed no significant difference in the hard endpoints of cardiovascular death or heart attack at 3 years. MACE was higher in the OMT group in EuroCTO, but that was driven by those patients needing more subsequent procedures due to ongoing ischemia, not by more deaths or MIs initially.
So the highest level of evidence doesn't currently support the survival benefit seen in the registries. How does the expert consensus reconcile this? What's the bottom line on prognosis?
The consensus takes a cautious, evidence-based stance. It concludes that, considering the limitations of the existing RCTs, maybe they weren't large enough, maybe they didn't enroll the highest-risk patients, the current evidence is still insufficient to definitively state that CTO-PCI improves prognosis by reducing long-term mortality or MI rates.
So it remains an area of active research and debate.
Absolutely. The potential is there, hinted at by registries, but not yet proven by RCTs.
Okay, one last outcome measure. Left ventricular ejection fraction, LVEF, recovery. We talked about viability, predicting potential recovery. After a successful procedure, does that stunned or hibernating muscle reliably wake up and improve the overall pump function?
This is another area where the evidence is still debated. Early observational studies, especially those focusing on patients who started with severe LV dysfunction but had clear viability on imaging like CMRI, did show some impressive improvements in LVEF after successful PCI.
That sounds promising.
It was. But then the main randomized trial designed to look specifically at this, the revascularisation trial, did not confirm a significant improvement in LVEF as a general finding after CTO-PCI compared to OMT.
Why the discrepancy? Any theories why revascularisation was neutral?
The main theory, mentioned in the consensus document, relates to the patient population in revascularisation. The average baseline LVEF in that study wasn't severely reduced. It was only mildly to moderately down, maybe around 55% or 60% on average.
So maybe there wasn't much room for improvement.
Exactly. If the heart function is already pretty good to start with, it's harder to show a statistically significant increase after the procedure. The feeling is that revascularisation might not have included enough patients with truly poor baseline function, say LVEF below 40%, to properly test the hypothesis of LVEF recovery.
But even if the overall LVEF number doesn't always jump up, is there still a link between fixing the ischemia and better outcomes for patients who do have LV dysfunction?
Yes, and this is an important nuance. A related finding showed that in patients with LV dysfunction, achieving a substantial reduction in the amount of ischemia after CTO-PCI, as measured by follow-up stress tests, was linked to significantly better long-term survival without death or MI. This benefit wasn't seen in patients with preserved LV function.
So reducing the ischemic burden in those weak hearts seems to matter prognostically, even if the ejection fraction itself doesn't dramatically change.
That seems to be the suggestion. It might be about preserving the remaining viable muscle and preventing further ischemic damage, rather than just seeing a numerical improvement in the LVEF percentage.
Okay, so summing up the LVEF situation, we can't promise routine LVEF recovery after CTO-PCI based on current RCTs, especially if function isn't severely impaired to begin with. And the group most likely to potentially benefit those with severe LV dysfunction and proven viability needs more focused study.
That's a perfect summary. That specific high-risk population is relatively underrepresented in the big trials so far. We really need large randomized studies dedicated to patients with LVEF, say under 35% or 40%, to definitively figure out the role of CTO-PCI in improving heart function and outcomes in ischemic cardiomyopathy. #tagoutro.
This has been a fascinating journey through the complexities of CTOs, the technical leaps, the imaging insights, and the ongoing debates about outcomes. Let's try to distill the absolute core message for everyone listening.
I think the key takeaway is that percutaneous CTO intervention in the right hands is now a very successful procedure technically. We're talking success rates of 85–90% routinely in expert centers, and importantly, with an acceptable risk profile, generally major complications in the 1–3% range.
And this is the crucial, but the primary proven indication remains improving symptoms. Relief from angina, relief from dyspnea, better quality of life. That's the solid win. The hope for reducing MACE or extending life is there, but it's not yet confirmed by the highest level of evidence.
Precisely, which means patient selection has to be careful and rational. It should be driven by symptoms, supported by imaging that confirms viability and significant ischemia, and ideally endorsed by that multidisciplinary heart team discussion, especially in complex cases.
It really highlights that tension we discussed, the compelling signals from large registries suggesting a survival benefit versus the randomized trials that haven't sealed the deal on that front yet.
Yeah, that disconnect between the large Korean registry showing that impressive 10-year mortality reduction and the neutrality of trials like Decision CTO on hard endpoints is the central challenge right now.
Which leads us to a final provocative thought for you, the listener. Could it be that this tension exists simply because the RCTs conducted so far haven't enrolled the right patients? Perhaps they were underpowered, or didn't focus enough on those who are most severely symptomatic, have the largest ischemic burden, or the worst LV dysfunction?
It's a critical question.
So the thought to leave you with is, how might future trials, designed specifically to be larger and to target these higher risk subgroups, finally settle this crucial debate? Will they confirm the prognostic benefit suggested by the registries and truly define the long-term role of CTO-PCI beyond just symptom relief? That's what the field is waiting to find out.
Definitely something to watch.
Thank you for watching The Funnel Effect.